Hello, everybody. My name's Chloe. I am the Practice Quality Improvement Coach for Perth Metropolitan Northwest. I've been a registered nurse since 2007, and I've worked in multiple roles across the tertiary systems and primary care. I'm passionate about using quality improvement methodology to assist practices in tailoring their care to their unique populations, especially looking at ways to target their care to those who require it the most and improve health outcomes for underserved populations. Connie?
So I'm Connie and I'm a quality improvement coach for Perth Metropolitan South East. I've been a registered nurse for over 13 years and have worked as a practice nurse and nurse manager in general practice, urgent care and women's health clinic settings. In my role as a QI coach, I work to support practices in a variety of ways, including helping general practice staff identify areas for improvement and implement solutions to create positive change. And I'll pass to Cass.
Hi, I'm Cassie. I'm the Quality Improvement Coach for Perth Metropolitan Southwest. I've been a registered nurse for 10 years and have experience in the primary healthcare, working as both a practice nurse and a nurse manager. I'm particularly passionate about multidisciplinary care, chronic disease management, and using data to drive improvement and supporting practices to develop meaningful quality improvement initiatives. And back to you, Chloe.
So we're going to take a look at quality improvement, or QI, breaking it down to the basics and what we need to know. So what is quality improvement? The Royal Australian College of General Practitioners, or the RACGP, define continuous quality improvement as an ongoing activity undertaken within a general practice, with the primary purpose being to monitor, evaluate, or improve the quality of healthcare delivered to practice patients. Quality improvement involves regularly reviewing and refining your practice systems, structures, and clinical care. Quality improvement activities are also a requirement for practices who want to be accredited against the RACGP standards and to be receiving the practice incentive QI payments. QI works best when it's embraced with a whole of team approach, ensuring consistency in messaging across the practice and that everybody understands their role in an activity. It can then drive positive change across key areas, such as better patient outcomes, enhanced patient safety, higher patient satisfaction, greater practice efficiency, a culture of continuous improvement, and it can support stronger, more viable business sustainability. At its core, QI helps primary care teams move beyond working harder and instead focus on working smarter, using simple methods to understand systems, test changes, and learn quickly. QI asks 3 essential questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we test that might lead to improvement? These principles help teams align around a shared goal, use data meaningfully, and experiment with manageable changes rather than large-scale overhauls. Quality improvement's nothing new. Practices are doing it every day, probably without realising it. The step that's often missed is to break down and document QI activities so systems and processes can be reviewed to ensure continuing improvement in service delivery and patient outcomes. Quality improvement, or QI, is evolving, and so is our mindset. Traditionally, QI was reactive. We waited for something to go wrong, often flagged during accreditation, responding to a crisis, complaint, error, or urgent demands. Although this is sometimes unavoidable, it limits our ability to get ahead of problems. The response was to quickly fix the issue and move on. Today, we're shifting to a proactive approach. Instead of asking, how do I fix what's broken? We can ask, how can I improve what's already happening? It's about anticipating needs, understanding patterns and processes before problems occur, using data to spot early warning signs, testing small changes in real time, and strengthening systems so issues are less likely to arise in the first place. This shift builds a culture where improvement is routine and continuous, not dependent on crises, external pressure, or a one-off project. This framework is called the Quintuple Aim for Healthcare Improvement, and was created as part of Australia's healthcare reform, focusing on the need for greater patient-centred care. We can use it to shape our improvements in ways that align with its 5 key principles. Some ways that you could address those principles in general practices might be looking at the criteria number 1, to improve the patient experience, you could focus on patient feedback by regularly gathering, analysing and acting on this to improve services and care experiences, or enhancing communication by training staff on patient-centred communication, such as a friendly and supportive email etiquette, ensuring that practices and patients feel heard and respected. Principle number 2 focuses on improving population health. You could promote preventative care by establishing systems to remind patients of relevant or scheduled screenings, vaccinations and checkups, or increasing health education by providing learning materials, workshops and in-practice sessions on healthy lifestyles to the community. Number 3 is reducing healthcare costs. For this, you could look at optimising resource use in the practice by undertaking regular internal audits to create more efficiency across staffing, equipment and resources by reducing waste and avoiding unnecessary duplication of services such as repeat tests. Or implementing telehealth, introducing telehealth options for your patients to reduce costs associated with in-person appointments, particularly for follow-up consultations or script repeats. Enhancing the wellbeing of your staff is the 4th principle. Improving in this domain might look like providing accessible support for burnout, implementing and encouraging the use of wellness programs, conducting regular check-ins, and providing access to mental health services and resources for staff to prevent burnout, or fostering a positive and supportive work environment, ensuring you create a culture that supports open communication, adequate staffing levels, and opportunities for professional growth and development. Finally, advancing health equity could focus on ensuring culturally competent care, training staff in cultural competency, and ensuring interpreters are available or easily accessible to assist care provision for patients who don't speak English, or removing barriers to care, identifying and addressing barriers such as transportation, language, or financial difficulties by partnering with community organisation or offering sliding fee scales. Quality improvement and the RACGP. The Royal Australian College of General Practitioners, or the RACGP, is the voice of GPs in Australia. They define their role as supporting the backbone of Australia's health system by setting the standards for education and practice and advancing for advocating for better health and wellbeing for all Australians. They cultivate a stronger profession by helping current and emerging GPs continue their professional development throughout their careers, developing resources and guidelines to support them in providing their patients with world-class healthcare and help with the unique issues that affect their practices. The RACGP has developed the standards for general practices with the purpose of protecting patients from harm by improving the quality and safety of health services. The standards also support general practices in identifying and addressing any gaps in their systems and processes. Practices can choose which accreditation agency they'll use, but every assessment is based on the RACGP standards. Often practices approach accreditation without actually realising this, and many staff don't realise the standards exist, yet this is exactly what they're being assessed on. That's why we always encourage clinics to include the RACGP standards in their onboarding, so everyone understands the foundation of accreditation from day one. We're presenting today using information from the 5th edition of the standards, which are the ones currently published and used for practice accreditation. Many of you will be aware that the 6th edition are being published at some point this year. Currently, there's no confirmed release date for these. However, what we do know is that practices will have some leeway on which standards they're accredited against while this transition takes place. The draft of the 6 standards is currently available for viewing online if anyone would like to. So looking at the standards for quality improvement, this slide outlines the RACGP indicators relating to QI activities. Here I'll highlight key areas for reflection and share some ideas to help you meet these criteria. Firstly, QI criteria 1.1a, the quality improvement team lead. For this criteria, you must have a QI team lead and ensure that person is educated about their role and responsibilities. You could reflect on who that team member is, who is responsible for QI in your practice. Typically, QI used to fall to the practice manager, but it's increasingly common for this to be a nurse's responsibility now, as practices are wanting to increase the QI activities that revolve around clinical outcomes, health promotion, chronic condition management, and data-led initiatives. At your practice, could you create a quality improvement team made up of members of the clinical and admin staff? It's very useful to have representation in the QI team across all areas, as each person can have input on how ideas or initiatives will affect or be affected by their particular area. You may need to document the responsibilities of the person responsible for QI in the position description to ensure that they maintain compliance in this area. The next two areas, QI 1.1b and 1.1c, are related to sharing information and getting feedback from your team. For these criteria, you must share QI and patient safety information internally. You must seek feedback from the team about QI and practice systems. You must have a system to identify quality improvement activities, and you must keep a record of feedback from the practice team about quality improvement systems. You could reflect on how your practice currently implements QI activities. Do you discuss these with your team before commencing? Do you get feedback from your team about how those activities went? Does your team have an opinion on planning for future QI activities? Could you utilise resources such as health promotion calendars to structure activities around upcoming health-related events? Could you allocate time in each team meeting to discuss quality improvement suggestions and feedback? Could you implement notice boards or suggestion and feedback boxes in the staff room that the team can use to contribute their ideas? This is a great idea for staff who are shy or may want to submit feedback anonymously. Could you create short surveys for the team to complete that are incorporated into a quality improvement plan? Lastly, criteria 1.1d. What were your practice quality improvements in the last 3 years? For this criteria, you must keep records of quality improvements made to the practice or practice systems in response to feedback, complaints, or audits, and be able to describe areas of improvement in your practice. You can reflect on whether all team members know what these are. Are they informed of the quality improvement activities? Could you include quality improvement as a standing agenda item at team meetings to keep team members informed? Would all team members know where to find your QI register? Is your QI register clear enough that anyone would be able to read it and know what activities were done without any prior knowledge? For example, instead of just listing flu vaccine in the register, which is quite vague, you could list something like SMSs sent to eligible patients to book for flu vaccine to improve vaccination rate. At this point, I will hand over to Cass to go through where to start.
Thank you, Chloe. So now that we know what quality improvement is and what is required, the big question is, where do you actually begin? So the steps that we need to take are: step 1, creating a quality improvement team. Step 2, nominating a quality improvement team leader. Step 3, identifying focus areas and setting SMART goals for quality improvement activities. Step 4, setting up QI infrastructure such as registers, templates, meetings, and visibility within the practice. And then step 5, planning the steps, implementing the change, and reviewing the outcomes and documenting the quality improvement activities. So step 1, forming your quality improvement team. To achieve sustainable quality improvement, it's important to involve all areas of the practice team in planning and implementation and reflection of quality improvement. When creating your quality improvement team, consider: Will every staff member be a part of the team, or will you have quality improvement champions representing different areas that then feed the information back to their colleagues? It's important that the people involved are the right fit. As much as we want everyone to participate in quality improvement, the reality is that everyone has different personalities and everyone has different workloads. Some team members love being involved in the decision making and planning, while others are happy to support and participate without being involved in every decision. Some of you might be wearing your management hats right now and might be thinking, why do I need to involve everyone? And this feels very time consuming. Why can't management just decide on the quality improvement projects and roll them out? The reason is that each team experiences the quality improvement activities differently, and involving everyone helps you identify impacts or issues you may not have considered. So let's run through an example of quality improvement activity that didn't involve a whole practice team. So let's say a nurse comes up with an idea for a quality improvement activity to increase women's health appointments. She sends out an SMS blast to patients due for cervical screening or a prescribed contraception saying, you are now due for a follow-up appointment. Please book a women's health appointment today. Although this is a great idea and the intentions were in the right place, this was done without consulting the team first. And what do we think the implications were? Firstly, the effect on the admin team. There'll be increased phone calls at reception. Did they have staff to cover the incoming phone calls? And were there already messages scheduled to be sent out today? Reception staff also didn't know what the message was about, causing confusion, incorrect bookings, and patients dismissing the message. And then we have the impact on the clinical team. Doctor availability wasn't considered. For example, female doctors could be on annual leave, either causing waiting periods or rescheduling. And asking which doctors want to participate also wasn't considered, and now there is a sudden increase of women's health appointments, reducing appointment variety in Doctor's Day, making it feel very repetitive. There is also now an increased use of resources and clinical equipment being used for cervical screening, increasing the workload for nurses in ordering and cleaning. And then we also have the patients. Patients may become frustrated with the confusion and poor organisation of why they were sent the SMS and why reception are unaware. And for the patients needing other care needs, they struggle to book in due to the influx of women's health appointments, and those that required urgent care or had an illness now have to book elsewhere. If this had been discussed with the team beforehand, clear workflows and processes could have been put into place, leading to a much more successful outcome. So you know you need a quality improvement team, but what if your team isn't fully on board with quality improvement yet? That's where building a strong quality improvement culture becomes really important. Organizational culture is often described as the system of shared value, what's important, beliefs, and how things work. These values and beliefs interact with people's structures and systems to shape everyday behaviors. If you want quality improvement to stick, we need to make it a part of everyday way of working. Some practical ways to start building quality improvement culture include holding a quality improvement kickoff meeting. This is an opportunity to talk about what is quality improvement and build a shared understanding, to start deciding who will be involved in the quality improvement team, assign clear roles, and agree on priorities and goals. Having an initial quality improvement meeting signals the importance of quality improvement and marks the beginning of a shared process change. Another useful strategy is setting up a quality improvement board that is visible to all staff. This can include a space for ideas, achievements, results, current quality improvement initiatives, and patient feedback. Having QI visible helps build encouragement, momentum, and shows staff that their efforts are making a real difference. Once quality improvement starts to feel familiar and visible, you can embed it into business as usual. You might do this by holding regular quality improvement meetings or adding quality improvement as a standing agenda item to clinical or staff meetings. This creates a consistent and safe way for staff to contribute ideas, raise issues, and stay engaged. It is also recommended to be implementing protected quality improvement time into the calendar for both the QI lead and the QI team to complete time-sensitive tasks, review data, and analyze the results. Protected time demonstrates an organization commitment to quality improvement and helps prevent improvement work from being squeezed out by daily appointments and pressures. And finally, make sure you schedule regular reviews of your quality improvement work as a whole. Here, you'll look back on all the activities you completed and ask what is working well, what's not working, what should we do more of, and what should we do less of? And is there anything we need to stop doing? Regular reviews keep quality improvement relevant, focused, and responsive, rather than being a set and big activity. When we're thinking about improving quality culture, it's important to remember that culture is dynamic. Observations, behaviors, and experience shapes attitudes and beliefs, and those beliefs then shape culture. Just like quality improvement itself, improving quality improvement culture starts with the people doing things differently or doing different things altogether. Small, consistent changes in their behavior are often what drive the biggest shifts in culture over time. So the next step is picking your quality improvement team leader. Chloe has already covered the RACGP requirements for a quality improved team leader, what they're responsible for and what needs to be documented. But beyond those formal requirements, the success of a quality improvement lead really comes down to the personality of the person in this role. An effective quality improvement leader is approachable, communicates well, and is curious about how things could be done better. They're organized but flexible, comfortable when things don't work out the first time, and are able to bring people along even without formal authority. Often this is somebody who's already making positive changes in your practice. They just don't realize that what they're doing is quality improvement. Now, it's really important to clarify something here, and that's being the quality improvement team leader doesn't mean this person is responsible for doing everything themselves. That's what we have a quality improvement team for. Tasks like planning, implementation, and activities and documentation are shared and delegated to people who are best placed to do them for each activity. The role of the QI lead is to coordinate and oversee and make sure activities are progressing and that the team members are capturing and documenting their work appropriately. So the quality improvement team lead isn't carrying the workload alone. They're making sure that the work that's already happening is visible, structured, and documented. So step 3, creating quality improvement activities and identifying focus areas. We'll be exploring some practical ideas for quality improvement activities shortly, which Connie will talk us through. So we're going to skip ahead to steps 4 and 5. So setting up infrastructure, and this includes how staff capture activities, document steps, and reflect on outcomes. So what are the templates you need to document quality improvement? This is where the QI tools come in, specifically the QI register and the PDSA. All quality improvement activities, no matter how big or small, go into the quality improvement register. And activities where you can monitor change and outcomes go into a PDSA. It's important to document the proposed quality improvement activity before beginning, and a PDSA is a perfect tool to do this. So what is a PDSA? PDSA stands for Plan, Do, Study, Act, and it's a systematic way to learn and change and continuously improve a process. Section 1 is Plan. This involves identifying a clear goal, a purpose, creating change ideas, forming a theory of what we think will happen, and deciding how we measure the outcomes and what we will be studying. When documenting the goal for a PDSA, it's essential to make sure it's a SMART goal. And I know what you're thinking, another acronym, but stay with me. So S is for specific. It clearly states what we're trying to achieve and who is involved. M is for measurable. How will we know we've succeeded and what will success look like on paper? A is for achievable, realistic within the time, resources, and context of your practice. R is for relevant, to make sure it aligns with priorities of the team, the practice, and your patient population. And T is for time-based. Every goal needs an end date. Without one, it can go on forever. A clear finish line gives you a moment that you can reflect on your work you've done and keeps your team focused and accountable. So using SMART goals helps teams stay focused, evaluate the progress effectively, and make meaningful improvements. So section 2 is the do phase. This is where you document every step needed to achieve the goal. This section should be 100% transparent, so someone should be able to pick it up and replicate it without asking for your help. So consider, do you need to create resources, templates, and autofill shortcuts? Do you need to have staff education? How we communicate this activity with your team? And what tools we'll be using to monitor success? And once this is documented, you implement the steps and begin the activity. Section 3, study. Here you analyze the data collected during the do phase. You compare the results to the expectations. You also want to identify what worked, what didn't, and why. Were there any challenges or barriers you faced or didn't expect, such as time constraints, staffing issues, and patient participation? And how did you overcome these barriers? And the final section is section 4, which is ACT. So based on your analysis in the study section, you decide either to adopt the change, adapt it and run another cycle, or abandon it. If the plan was successful, you may choose to implement it on a larger scale. This is recorded as adopt. If the activity didn't work out as planned, but you don't currently have the time or the resources to refine and retest it, you may choose to abandon it. This doesn't mean that it failed, it simply means that it's not the right time to continue. If the activity wasn't successful, but you can see opportunities for improvement, you would adapt the change and run through the cycle again. An important thing to remember is that a PDSA is a continuous improvement process. It can be repeated over and over. If a PDSA needs changes, there is no need to delete it or overwrite your previous work. Instead, duplicate the PDSA document. Make amendments to the new document, updating the start date to when the changes were implemented, and close the previous PDSA document by adding the same date as the finish date. Each PDSA builds on the one before, leading to incremental improvements over time, and the previous unsuccessful PDSA shows you reflections and lessons learned, which is all a part of quality improvement. Showing your failures is incredibly important. Not only does it demonstrate how you improved a process over each cycle, but to show that you cared enough to try and you cared enough to keep going. Failures demonstrate reflection, learning, and commitment to improvement. They show that quality improvement is about getting it right the first time. It's about learning what works and what doesn't. On the screen, I've included 2 of my favorite quotes, and I think they really capture the importance of not only attempting quality improvement, but also documenting and evaluating the attempts that didn't work. Because in quality improvement, those failed attempts are often where the most valuable learning happens. So in summary, a PDSA cycle is a simple yet powerful tool for continuous improvement. By planning carefully, implementing thoughtfully, studying the results, and acting on what you've learned, you can create meaningful and sustainable change. If you don't already have these processes in place, you must be thinking, this sounds like a lot of work. But a quality improvement register and a PDSA aren't about creating more work. They're about capturing and recognizing the great work you're already doing, especially with areas such as accreditation preparation, where so much effort goes unrecognized. And this is a way to showcase all of those achievements. So I'm now going to hand over to Connie, who will take us through some quality improvement activities.
Thanks, Cassie. Okay, so in this next section, we'll examine the types of quality improvement activities used in practice and discuss the key differences between them. So the reason why quality improvement is essential to general practice is because it demonstrates a practice's commitment to ongoing reflection, learning, and improved outcomes. Any work done to improve or maintain areas of your practice in line with the Quintuple aims can be and should be documented in your quality improvement register. So for example, have you implemented a new policy? Have you implemented new templates for health assessments or care planning? Have you conducted an audit? Have you acted on patient feedback? Have you introduced workflow enhancements? Or have you recently completed staff training? All of these are QI activities. Now, quality improvement isn't only about data and numbers, it's also not just about feedback and stories either. So in practice, QI can be done using quantitative methods, qualitative methods, or a combination of both. Understanding the difference helps you choose the right approach for the improvement that you're trying to make. Now, quantitative methods focus on measurable data. They help us track performance, identify trends, and see where the changes lead to improvement. Qualitative methods help us understand the why behind the numbers by capturing patient and staff experiences, perceptions, and insights. In primary healthcare, both matter because together they give us the complete picture. For example, quantitative data might display high no-show rates, while qualitative feedback helps us understand the reasons, such as maybe transport issues or missed reminder messages. When we combine both approaches, we're able to design improvements that address not just systems and processes, but also the human experience. So when we talk about quality improvement, always remember, it's not just about counting, and it's also about listening, learning, and improving care in ways that truly matter. Now, training and continuous professional development, or CPD, can also contribute to quality improvement. So CPD and quality improvement are naturally linked. CPD is great for spotting where things could be better, like when you discover gaps after learning about new clinical guidelines. Those light bulb moments are exactly what kicks off quality improvement activities. QI activities allow healthcare professionals to apply what they've learned through continuous professional development and measure its impact, often leading to better patient outcomes. CPD that contributes to quality improvement in your practice can, of course, be documented in your QI register. So let's take a look at getting started on a QI activity in your practice. Now, as we touched on earlier, keeping patient information up to date takes teamwork. So we've got receptionists, nurses, allied health professionals, and GPs that all need to work together to make sure every active patient has a current health summary. The RACGP standards state that every active patient should have key information in their record, like allergies and a current health summary. Active means that the patient has been to the practice at least 3 times in the last 2 years. To keep data accurate, we need regular cleanups, archiving anyone who's no longer active. And this isn't just good practice, it's a quality improvement activity that helps us really understand our patient population. Ideally, every active patient would have an up-to-date health summary, but at the very least, RACGP expects allergies to be recorded in 90% of patient records and current health summaries for at least 75%. Even if a patient has no allergies, you don't leave it blank. This makes sure everyone is on the same page, whether it's in the practice, on your referrals, or on My Health record. If you're using a hybrid system, allergies should be recorded where you prescribe. Now, updating health summaries and improving data quality is a valuable quality improvement activity, and it's one that we see commonly implemented by practices. We're always happy to guide you through the processes, and we have multiple ways we can assist you. So, for example, practices that use Primary Sense might be aware there's a report called Accreditation that displays this data. We can provide suggestions and simple PDSAs around improving this data and the processes around collecting it. Now, how can you review your practice data to decide who requires your attention first? So thankfully, WAFA's already thought of that. We have the Primary Care Reporting Portal. The Primary Care Reporting Portal, or PCRP, is an online system designed for general practices who share data with WAFA via Primary Sense to manage and provide timely, safe, secure, and reliable real-time access to your practice's data summaries. The portal is an encrypted platform and uses validated access control, ensuring a safe and secure method for delivery and access for practices while providing real-time reporting of practice information. Now, I won't go through all of the pages of reports available on PCRP, but I'll just highlight a few areas that can be a great starting point before you'll take a look at your own practice reports after this session. So here's the demonstration view of the patient demographics slide, which is great for assessing who your practice population actually are. So in this demonstration example, there's a higher proportion of female patients aged 18 to 34 than any other group. So it might suggest that the practice has GPs with interests in fertility or obstetrics. Or if not, maybe it's an area the practice could look at expanding into. Now, if you were then to select this particular age group in the table, all the other tables and graphs will automatically show you the statistics based on your selection. In this example, we can see that of this age group, there is a high number of patients with a moderate ACG complexity level score. So they're typically having at least one chronic condition. Some QI options here may include a large-scale health promotion project focusing on these patients, or perhaps a smaller scale project focusing on patients in this age group with a high complexity score. If you hover over the data field, it will show you the number of patients in the selected group. Honestly, the possibilities may feel endless, which is why having your QI team, as Cassie highlighted earlier, is so important in deciding which QI initiative your team has capacity for. So with the insights from the primary care reporting portal, it's fairly simple for practices to spot what their patients need and to pick out areas to focus on. By checking out the age groups and complexity scores, your team can come up with practical plans and projects that actually make a difference, matching what your patients need with what your team can realistically do. It's all about making things better for everyone without biting off more than you can chew. So here we have the Cancer Screening and Health Assessments tab, which is particularly useful for identifying gaps in cancer screening and health assessments. It shows which patients need screening, making it easy for a team to plan ways to boost participation, especially during health promotion months. Focusing on these health promotion activities not only improves screening rates, but it can also bring the staff and patients together in a fun and positive way. So now that you've identified your target population, let's look at how you can find them and then provide the right services. Now, one way to kick things off is by making the most of those moments when the patient first walks in. So getting your reception and admin team in the habit of looking out for extra opportunities to help, right from that first hello. When the patient walks in, your receptionist could consider, how old is the patient? What brings them in today? Is there a chance that they could benefit from some extra services? Do we have time to offer these services today? If not, when is the next slot available and can we get them booked in? As for patients who aren't showing up in person, let's talk about how you can use your practice's data to find them and then make sure they get the care that they need. So Primary Sense is one such program, which is a population health management, clinical decision support, and data extraction tool designed for general practices. It provides real-time alerts, reports, and patient care prompts to help GPs deliver the right care at the right time. Hopefully your practice is already using it, and if you have it but aren't familiar with how to use it, please contact us for a full demonstration. Now, within Primary Sense is a menu of reports to help identify patients. As highlighted here on the slide, there's several reports available that could be really relevant to your practice. To illustrate the process, let's focus on the steps you might follow after reviewing your own practice's data insights on the primary care reporting portal. So in this scenario, the team has collectively decided to prioritize increasing health assessments. So by following these steps, your practice can effectively focus efforts on increasing health assessments, making meaningful impact while keeping the process manageable and tailored to your team's capacity. So for today, we'll look at the demo version of the health assessment report. And this report provides lists of patients who may be eligible for proactive care through a health assessment. The report includes 4 tables, enabling practices to easily identify and recall patients aged 40 to 49 who may be eligible, Aboriginal and Torres Strait Islander patients, patients aged 75 and over, and then women aged 35 to 55 who are eligible for the new menopause or perimenopause health assessment. Once you've exported this to Excel, the data can be filtered by the columns seen in the report, such as your ACG score, allowing you to target the most at-risk patients, last visit, existing appointment, or age. From here, you could look at inviting those eligibles in for an appointment. Now, as Cassie mentioned earlier, this is where documenting the process using a PDSA becomes really valuable. It allows you to look back at your recall process and analyze whether it's actually effective or is there a better approach. So, for example, you might spend hours making phone calls to patients eligible for 45 to 49-year-old health assessment, but when you review your results, you're finding that bookings are still really low, maybe because many patients aren't answering their phones. That insight allows you to adapt your process and test a new cycle, such as maybe switching from phone calls to SMS messages. If you find your process works really well in your practice, then why not use the same method for other quality improvement projects? So just keep reviewing your data, pick out the right reports, and invite patients in as you did here. It's an easy way to keep making positive changes. Now, if you happen to look at your practice data and you feel really overwhelmed with where to even begin, then you can get in contact with your local WAFA QI coach. If you haven't worked with us yet, quality improvement coaches can provide tailored support, resources, and expertise. We can help identify areas for improvement and implement solutions, and use data-driven approach to effectively drive quality improvement. We also help your team develop skills to tackle new quality improvement initiatives, promote a multidisciplinary team-based approach to quality improvement, and we can provide assistance in documenting and capturing your QI in your QI register or the PDSA. Our team work to deliver external support to primary care practices to improve the Quintuple aim outcomes. We do this in a variety of ways, but mainly by being adaptive to your practice and your team's QI needs. Please do reach out with the contact details on the slide there. And we also do webinars. So another way we support practices is through education sessions like today's one that you can access at any time or as many times as you want. Now you can just visit our WA Primary Health Alliance YouTube channel to have a look at the previous recordings that you might have missed. And I'll hand back to Jamie.
Lovely. Thank you, Connie, and thanks, Chloe and Cass, for what you've shared with us. So I have a couple of questions. The first one being, does onboarding staff to new software count as a QI activity for a PDSA because I can count the number of staff?
I will answer this one. So the question I would ask back to this is, why do you want it to be a PDSA? Because technically, yes, you can count the number of onboarding, like how many staff you've trained. So technically, you can measure it. But just because you can measure, you can count something, doesn't mean it has to be a PDSA. What we need to think of is, what are we actually trying to learn here? What is your SMART goal? And what are you trying to study? If you're using it to understand a process, how long onboarding is taking, or how many steps are involved, or lots of problems are coming up, then yeah, a PDSA does make sense because you're going to do reflection and learning. But if you're just recording it for the sake of recording a PDSA, sort of like ticking it off a checklist because you don't have any PDSAs, then I would recommend a different kind of activity to record for a PDSA, such as one of the ones Connie has mentioned earlier. And for this one, just place it in your quality improvement register. I hope that kind of made sense for you guys.
Lovely. Thanks, Cass. The next question is, how do we choose which data to focus on?
I can maybe answer that one. Lots of data can seem really, really overwhelming. So looking at, say, the PCRP or primary sense like Connie showed us, you can kind of want to go and start fixing the world. But it is yeah, you do have to choose something. At WAFA, we focus on really targeting the underserved population, so demographics of high priority, like Aboriginal and Torres Strait Islander patients. So you could focus on offering those patients sort of closing the gap services like the additional vaccinations, or you could focus on health assessments, something like that. Or some practices choose a bit of a formula. They might do one QI activity around admin sort of data, such as updating the ethnicity status of patients at the front desk, one focusing on preventative health, such as increasing cervical screening, and one focusing on chronic disease, such as recalling patients on care plans for reviews, or making sure every diabetic patient has an up-to-date HbA1c. Or you could just focus on something that is interesting to you, because if it's something you're doing, you might as well be enjoying it, and you might as well be knowledgeable about it and be able to really make a difference. So it's sort of a choose your own adventure within the realms of the skills and capabilities that you can offer at the practice.
Lovely. Thanks, Chloe. And the last question is, we are an extremely busy practice. What if we just don't have time for quality improvement?
I can answer this one. This is a really common question. Like, we just hear this all the time, and we've all worked in general practice, so we can really relate to this. So quality improvement isn't necessarily about adding extra work to what is already a crazy busy day. It's more of reframing it to look at, can we fix things that are slowing us down or frustrating us in our daily tasks? Always as well, like, QA just works best when you start small and then just build on it. Even if you're just doing little small steps every day, it's always going to make a difference. Whether that be like a handover thing or looking at improving a process. And that might improve workflows later on down the track, which will hopefully make you feel less busy. So often, we do find where if a team is saying they're feeling really busy, then it's a good sign that maybe they need to look at doing some quality improvement that could help with that. So yeah, hopefully that answers that one.
Thank you, Connie. Perfect. Well, that brings us to the end of our Q&A section. And I just want to thank our QI coaches again for what you've been able to share with us this afternoon. And I'm sure there was a lot of information to consolidate. So if you do find that you do have some questions after this webinar, you are more than welcome to reach out to any of our QI coaches, whose details you will also have after the webinar. And I want to thank you all for attending. I do have a QR code on the screen, and I've just popped the link to the feedback form in the chat. So if you do have a couple minutes, we would really encourage you to fill out that feedback form. It just informs a lot of the events that we run here at WAFA, and we want to make sure that today's webinar was valuable for you and any topics you may be interested in the future as well. If you're on the Florence app, you're also more than welcome to log this as your CPD on there, and the QR code for that is on the screen, and you will also receive that in the email after this webinar. And just to close, we have a save the date. On the 3rd of June, we'll be having our second installment of our QI series. There will be more details to follow, and we will send you an email with the link to the registration page once that is out. So please keep your eye out on our socials and on your emails. If you've enjoyed what you've been able to gather from the webinar today, I can assure you that you will be able to get more for your practice at the next one. So stay tuned for that. And like the girls have mentioned earlier, we also have our YouTube channel. I'll just put that up again. If you are new to our QI series, we have run these in the past as well. You're more than welcome to have a look at some of those videos that are up there as well. And on behalf of all of us, we thank you for joining and wish you a lovely afternoon.